There are 5 warning signs doctors pay very close attention to when caring for someone over 70. And when several of them begin appearing together, they can suggest something more important than any single diagnosis. The body may be losing its ability to recover. That matters because serious decline in older adults does not always begin with one dramatic event. Sometimes it starts quietly. A person may still be eating breakfast, talking with family, watching television, and following the same routine they have had for years. From the outside, very little seems to have changed. But underneath that normal routine, recovery may be becoming slower, strength may be fading, and each new health problem may be taking a little more away than the last one. This is where doctors begin to pay attention to patterns. A fall is no longer just a fall if it leads to weeks of inactivity. A heart problem becomes more concerning when simple movement suddenly causes exhaustion. Poor nutrition matters more when it is followed by visible muscle loss. A long medication list becomes important when weakness, dizziness, or confusion begin to appear. And repeated hospital stays can signal that the body is struggling to return to its previous level of health. When these problems begin connecting, the prognosis can become much more serious. In some older adults, that pattern is associated with a significantly higher risk of dying within the following year. But that does not mean any one of these signs is a prediction. Having one does not mean you, or someone you love, has 12 months left to live. Medicine cannot predict life that precisely, and people sometimes recover much better than expected. The real value of recognizing these signs is that they can tell you when it is time to stop treating each problem as an isolated event. That may mean protecting mobility before more strength is lost. It may mean improving nutrition, reviewing medications, managing heart disease more carefully, or asking why someone keeps returning to the hospital instead of simply treating the newest problem and moving on. So this list is not meant to frighten you. It is meant to help you notice when several small changes may actually be telling one larger story. We are going to count down from number 5 to number 1. And the final sign is especially important because it can bring all the others together. For the sake of your health, please watch this video until the very end. The information we're about to share is truly important, especially for anyone over 70. Before we start, let us know in the comments. How old are you? And where are you watching from? We'd love to see where everyone in our community is joining us from. Let's begin with number 5, a hip fracture followed by a major loss of mobility. At first, this may seem like an injury problem. Someone falls, breaks a hip, goes to the hospital, receives treatment, and begins recovery. The natural assumption is that once the fracture has been repaired, the biggest danger has passed. For an older adult, however, the fracture can sometimes be only the beginning. Imagine a 78-year-old man named Thomas. Before his fall, he was not an athlete, but he was independent. He walked to the mailbox, made his own lunch, showered without help, and went grocery shopping with his daughter once a week. Then one evening, he loses his balance while turning too quickly in the kitchen. He fractures his hip and is taken to the hospital. The procedure goes well. His family feels relieved. But several days later, they notice something unexpected. Thomas barely wants to leave the bed. Walking hurts, so he avoids it. Because he moves less, he becomes weaker. Because he feels weak and tired, his appetite falls. Soon, standing beside the bed requires more effort than walking across his house did before the accident. This is the part of a hip fracture that families often underestimate. For someone over 70, prolonged immobility can affect far more than the injured hip. When a person spends much of the day lying down or sitting, the muscles that support standing and walking are no longer being challenged in the same way. Strength can decline quickly, especially in someone who already had limited muscle reserve before the fall. And once movement decreases, other problems can begin to follow. Taking fewer deep breaths and spending long periods in bed can contribute to respiratory complications, including pneumonia. Reduced movement can increase the risk of blood clots. Hospital stays and surgical recovery can also bring the possibility of infections. Then nutrition may begin to suffer at exactly the moment the body needs it most. Pain, medications, unfamiliar surroundings, poor sleep, and illness can reduce appetite. If someone is eating less protein and fewer calories while simultaneously losing muscle from inactivity, recovery becomes even harder. There is another change families should watch for: sudden confusion. An older adult who was mentally sharp at home may become disoriented or unusually sleepy during hospitalization. This can be delirium, and it deserves medical attention rather than being dismissed as simply getting old. Now, several problems can begin reinforcing one another. Less movement leads to weakness. Weakness makes movement harder. Poor appetite slows recovery. Confusion can interfere with rehabilitation. And when the person finally tries to walk again, weaker legs and poorer balance can increase the risk of another fall. That is why the early period after a hip fracture matters so much, particularly the first couple of weeks. The goal is not to push someone beyond what is medically safe. It is to prevent unnecessary immobility while recovery is taking place. If the medical and rehabilitation team says it is safe, getting a person sitting up, standing, and gradually moving again can be an important part of recovery. Physical therapy is not simply about learning how to use the repaired hip. It is also about rebuilding confidence, balance, and enough strength to return to everyday activities. Prevention matters just as much. Look around the home before a fall happens. Loose rugs, poor lighting, cluttered walkways, slippery bathroom floors, and frequently used objects stored too high or too low can all turn an ordinary movement into a dangerous one. Nutrition also deserves attention. Older adults need enough calories and protein to maintain muscle and support recovery. Vitamin D and bone health should be discussed with a healthcare professional, especially when there is a history of falls, fractures, osteoporosis, or deficiency. And don't wait until someone has already become frail to think about muscle. Regular, appropriate strength and balance activity can help preserve the physical reserve a person may need if an illness or injury occurs later. Because after 70, mobility represents much more than the ability to walk across a room. It is the ability to get out of bed without assistance, to use the bathroom independently, to prepare a meal, to leave the house, to remain connected to other people, and often to continue living life on your own terms. A hip fracture can threaten all of those things when it leads to prolonged immobility. If you think a hip fracture is serious, keep watching, because the next sign can be even more dangerous. And unlike a fall, it may be getting worse without you even realizing it. Number 4 is a severely reduced ejection fraction. There may be no fall, no sudden injury, and no clear moment when the family realizes something has changed. Instead, the clues can appear gradually. An older adult who once walked to the end of the street now stops halfway to catch their breath. Climbing a few steps becomes exhausting. Shoes feel tighter by evening because the feet and ankles are swelling. Sleeping flat becomes uncomfortable. Activities that were routine a few months ago suddenly require much more effort. To understand why, we need to talk about a number called ejection fraction, or EF. Think about what the heart has to accomplish every minute of every day. It receives blood and then contracts to send part of that blood forward through the body. Ejection fraction measures the percentage of blood pumped out of the heart's main pumping chamber with each contraction. A typical left ventricular ejection fraction is often around 55 to 70%, although the exact interpretation depends on the individual and clinical context. The concerning situation for this discussion is when that pumping ability becomes severely reduced. An EF around 20% or below represents significant heart dysfunction. And when an older adult with severely reduced EF is also being hospitalized for heart failure, doctors take the overall prognosis very seriously. Why? Because the heart is not working in isolation. When it cannot move blood forward effectively, pressure can build behind it. Fluid may accumulate in the lungs, making breathing difficult, or collect in the legs and other tissues, causing swelling and rapid changes in body weight. A patient may enter the hospital short of breath, receive treatment, lose excess fluid, feel better, and return home. But if the underlying heart failure remains severe, symptoms can return and another hospitalization may follow. There is also another concern that families may never see coming. A severely weakened heart can be associated with dangerous abnormal rhythms. In some people, these electrical disturbances can become life-threatening, which is one reason cardiology follow-up is so important when heart function is significantly reduced. But there is an important difference between saying, "This is serious," and saying, "Nothing can be done." Those are not the same thing. Consider Margaret, 76, who begins noticing that carrying laundry from one room to another leaves her unusually breathless. She assumes she is simply getting older and starts avoiding activity. A few weeks later, swelling develops around her ankles. Her daughter encourages her to get evaluated, and testing shows that her heart's pumping function is severely reduced. For Margaret, that result is not a prediction of exactly what will happen next. It is information that changes what needs to happen next. She now has a reason for closer cardiology follow-up. Her medications can be reviewed and adjusted by her medical team. Her symptoms, blood pressure, fluid status, and other health conditions can be monitored. Her doctor can advise her on appropriate nutrition and how much activity is safe for her particular condition. Repeat echocardiograms may also help determine whether heart function is improving, stable, or worsening. And importantly, some people with reduced ejection fraction do improve with appropriate treatment. That is why the worst time to begin thinking about heart health is after repeated episodes of severe heart failure. If you already have heart disease, keep your follow-up appointments and understand what your doctors are monitoring. If you've had an echocardiogram, ask what your ejection fraction means in your specific situation. Rather than focusing on the number alone, and if new shortness of breath, swelling, unusual fatigue, chest symptoms, fainting, or a sudden decline in exercise tolerance appears, don't simply assume it is a normal part of aging. Those changes deserve medical attention. Because after 70, protecting the heart is not only about preventing a heart attack. It is also about preserving the heart's ability to support every other organ and preserving enough physical reserve to recover when something else goes wrong. And if you think a severely weakened heart sounds concerning, keep watching. Number 3 can be easier to overlook because it may first appear as nothing more than an abnormal number on a routine blood test. But that number can reveal something much bigger about nutrition, muscle loss, and the body's ability to recover. Number 3 is a very low albumin level. You may simply see the word albumin on a blood test, glance at the number, and move on. Albumin is a protein made by the liver and found in the bloodstream. Among its many functions, it helps keep fluid inside the blood vessels rather than allowing too much of it to move into surrounding tissues. In many laboratories, normal albumin is roughly 3.5 to 5.0 grams per deciliter, although reference ranges vary. A value around 4 may be reassuring in the right clinical context. But when albumin falls substantially, particularly toward 2.5 or below, it deserves attention. The important question is not simply, how do we raise this number? The better question is, why is it falling? Consider a 79-year-old woman named Helen. Over several months, her family notices that she is eating smaller meals. Breakfast becomes coffee and toast. Lunch is sometimes skipped. Dinner may consist of only a few bites because she says she isn't hungry. Her weight has not changed dramatically, so nobody is especially worried. But Helen is changing. Her arms look thinner. Getting out of a chair takes more effort. She walks less because she feels tired. After a minor illness, she takes much longer than expected to regain her strength. Then blood work shows that her albumin is low. Low albumin can occur in several situations, including inadequate nutrition, inflammation, liver or kidney problems, and advanced chronic illnesses such as heart failure. That is why it should be interpreted by a healthcare professional alongside the rest of the person's health picture. But when poor food intake, muscle loss, weakness, chronic disease, and low albumin begin appearing together, the pattern becomes much more concerning. The body needs adequate energy and nutrients to maintain tissue and recover from illness. If an older person eats poorly, muscle can be lost. With less muscle comes less strength. Less strength can mean less movement. Less movement can further reduce appetite and independence. Then the next illness arrives, and the body has less reserve available to deal with it. Very low albumin can also be associated with swelling. When there is not enough albumin, contributing to keeping fluid within the circulation, and especially when other illnesses are present, fluid may collect in areas such as the legs or abdomen. So nutrition after 70 should never be judged only by the bathroom scale. Someone can maintain a similar body weight while losing valuable muscle. The more useful questions may be: are they eating enough? Are meals providing adequate protein and energy? Are they becoming weaker? Are clothes fitting differently? Has their ability to stand, walk, or recover from illness changed? Protein becomes especially important here. Rather than leaving most of it for one large evening meal, it can be helpful to include a meaningful protein source throughout the day, according to the person's medical needs. Breakfast might include eggs with oatmeal. Lunch could include lentil soup with chicken. A snack might be plain yogurt with walnuts and strawberries. Dinner could include fish, beans, or another appropriate protein source, alongside vegetables and other nourishing foods. The goal isn't to chase one laboratory number by eating enormous amounts of protein, and some older adults, particularly those with certain kidney, liver, or other medical conditions, may need individualized nutritional advice. If albumin is low, the underlying reason needs to be evaluated rather than assuming food alone will correct it. When eating becomes so difficult that a feeding tube is being discussed, that can also indicate that a person's overall medical condition has become much more serious. Decisions about artificial nutrition are highly individual and should involve the patient, family, and medical team. The larger lesson is simple. Food after 70 is not merely about controlling weight. Nutrition helps support muscle. Muscle supports mobility. Mobility supports independence. And together, they help give the body more reserve when illness or injury occurs. If you think a very low albumin level is concerning, keep watching, because number 2 isn't about something missing from the body. Number 2 is polypharmacy, taking many medications at the same time. One prescription is started for blood pressure. Another is added for diabetes. Later comes something for pain, something for sleep, perhaps another for the stomach, bladder, cholesterol, or anxiety. Years pass. Doctors change. Hospital visits happen. Eventually, someone opens the medicine cabinet and realizes there are 10 different bottles sitting there. In medicine, the term polypharmacy is commonly used when a person takes multiple medications, often 5 or more. Once the list reaches 10 or more, the situation becomes increasingly complex. And in older patients with several chronic illnesses or repeated hospitalizations, medication lists can sometimes become much longer. But we need to make an important distinction. Taking many medications does not automatically mean those medications are causing someone's health to decline. Someone taking 10 prescriptions may simply have several serious medical conditions that require treatment. In other words, the long medication list can sometimes be a marker of illness rather than the direct cause of a poor prognosis. Still, the medications themselves deserve careful attention. As the number of drugs increases, so does the possibility of side effects and interactions. And after 70, those effects may not always appear in an obvious way. Consider Robert, 81. He has managed high blood pressure and diabetes for years. After developing back pain, another medication is added. Months later, he begins having trouble sleeping, so he receives something for that as well. Then his daughter notices a change. Robert is sleeping later in the morning. When he stands up, he occasionally feels lightheaded. His walking seems less steady, and he has stopped taking his usual afternoon walks because he says his legs feel weak. Everyone assumes he is simply slowing down with age. But what if part of the problem is medication-related? That question matters because dizziness, sedation, confusion, weakness, or changes in blood pressure can increase the risk of falls and make it harder for an older adult to remain active. And sometimes another problem appears: the prescribing cascade. Imagine that one medication causes ankle swelling. Instead of recognizing the swelling as a possible side effect, it is treated as a new medical problem and another drug is prescribed. That second medication creates dizziness. Now the dizziness is treated separately. Before long, 3 medications may be involved in a chain that began with the side effect of the first. This does not mean doctors are intentionally overprescribing. Older adults often have complex medical needs. Prescriptions may come from several specialists, and a medication that was appropriate 5 years ago may simply remain on the list because nobody has stopped to reconsider it. That is why medication review becomes so important. At your next appointment, bring an accurate list of everything you take. That includes prescriptions, over-the-counter medicines, and supplements. If possible, include the dose and how often each one is used. Then ask simple questions. Why am I taking this? Is it still necessary? Could any of these medications be interacting with one another? Could one of them be contributing to my dizziness, fatigue, confusion, or weakness? And perhaps most importantly, if this medication was intended to be temporary, what is the plan for eventually reducing or stopping it? There is one rule that matters enormously here. Do not suddenly stop prescription medications on your own, simply because the list seems too long. Some drugs can cause serious problems when discontinued abruptly. Deprescribing should be a deliberate process, carried out with the appropriate healthcare professional, who can determine what should remain, what might be adjusted, and what may be safely removed. The goal is not to take as few medications as possible. The goal is to take the medications you genuinely need, at appropriate doses, for clear reasons, and to periodically reconsider whether yesterday's treatment still makes sense for today's health, because more pills do not automatically mean better care. Sometimes good care means adding the right treatment. Sometimes it means changing one, and sometimes it means carefully removing something that is no longer helping. Number 1 is recurrent hospitalization. One hospitalization does not necessarily mean someone is declining. A person can develop an infection, receive treatment, recover well, and return to the life they had before. What concerns doctors is a different pattern. Someone comes home from the hospital, but never quite returns to where they were before. Then another problem occurs, and then another. Consider 82-year-old James. At the beginning of the year, he is living independently. He cooks simple meals, walks around his neighborhood, and manages most daily activities without assistance. Then he falls and fractures his hip. After surgery, James spends several days in the hospital and then moves to a rehabilitation facility. The fracture begins healing, but he is moving much less than before. His legs become weaker and his appetite declines. Eventually, he returns home. His family is relieved. But James is not really the same James who entered the hospital. Before the fall, he could walk to the kitchen without thinking about it. Now he needs a walker and rests halfway down the hallway. He eats less. He sleeps more. His daughter begins helping him shower. A month later, James develops pneumonia. Back to the hospital. He receives treatment and improves enough to leave, but this time recovery is slower. During the admission, he becomes confused for several days. He spends more time in bed. Another medication is added. When he returns home again, he needs even more help. Then several weeks later, swelling and shortness of breath appear. Another ambulance. Another hospital room. Another setback. This is the pattern behind number 1. The important issue is not simply how many times someone has been admitted. It is whether they are recovering back to their previous level between those admissions. A younger, healthier person can experience a serious illness and sometimes regain most of what was temporarily lost. For a frail older adult, recovery may look very different. Imagine health as a series of levels. Before the first hospitalization, someone may be walking independently, preparing meals and managing medications alone. After discharge, they recover, but now need a cane. After the second hospitalization, they recover again, but now need help bathing. After the third, they may no longer be able to live safely without daily assistance. They are recovering each time, but they are recovering to a lower level. That is what makes repeated hospitalization such an important warning sign. And now you can see how the previous 4 signs begin to connect. A hip fracture can reduce mobility. Reduced mobility can accelerate muscle loss and increase complications. Poor appetite and chronic illness can contribute to worsening nutritional status. Heart failure can lead to fluid buildup and another admission. Each hospital stay may result in medication changes, making an already complicated medication list even longer. Meanwhile, the body has less strength available for the next challenge. Hospitalization itself can also be difficult for an older adult. Unfamiliar surroundings, interrupted sleep, illness, procedures, and medications may contribute to delirium. Spending days in bed can worsen physical deconditioning. Appetite may fall. Hospital-acquired infections can occur. And even after the original medical problem improves, strength and independence may take much longer to return. So when someone over 70 has been hospitalized 2 or 3 times within a short period, the question should not only be, what are we treating this time? Another question becomes equally important. Why does this keep happening? Perhaps heart failure is not adequately controlled. Perhaps a medication is contributing to falls. Maybe the person is returning home without enough rehabilitation support. Maybe poor nutrition is slowing recovery. Perhaps an infection keeps recurring because an underlying problem has not been addressed. This is where good transition of care planning becomes extremely important. After discharge, follow-up with the primary care doctor should not be treated as an afterthought. The medication list may need to be reconciled. New prescriptions should be compared with old ones. Specialists may need to become involved. Changes in mobility, appetite, cognition, breathing, or the ability to perform daily activities should be discussed. And recovery should not be measured only by whether the original disease has improved. Ask whether the person is walking again. Are they eating enough? Can they get out of a chair? Can they use the bathroom safely? Are they mentally back to their usual self? Can they still manage the activities they could perform before entering the hospital? Those questions can reveal decline that a laboratory result may miss. And sometimes, despite appropriate treatment, the pattern continues. If hospitalizations become more frequent, while strength, independence, and quality of life continue to fall, it may also be time for a thoughtful conversation about goals of care. That does not mean giving up. It means asking what the person values most and making sure future medical decisions reflect those priorities. For one person, the priority may be pursuing every reasonable treatment that could extend life. For another, it may be remaining comfortable at home and avoiding burdensome interventions that are unlikely to restore the independence they value. Those conversations belong to the patient, their family, and their healthcare team. Don't look at repeated hospitalizations as completely separate events. Look at what happens between them. If each illness leaves an older adult weaker, less mobile, less nourished, more dependent, and less able to recover, the pattern itself is telling you something important, and recognizing that pattern earlier may create the opportunity to interrupt it. Or, when that is no longer possible, to make more informed decisions about what comes next. If there is one thing I want you to remember from these 5 warning signs, it is this. None of them should be treated as a prediction of how much time someone has left. A hip fracture, a severely reduced ejection fraction, low albumin, a long medication list, or repeated hospitalizations cannot tell us exactly what will happen to one individual, but they can tell us when it is time to pay closer attention. Because after 70, health is not measured only by blood pressure, laboratory numbers, or the number of diagnoses written in a medical chart. It is also reflected in something much more practical: how well you recover. Can you regain your strength after an illness? Can you continue walking and caring for yourself? Are you eating enough to support your body? Are your medications still helping more than they are hurting? And after leaving the hospital, are you truly returning to your previous life? or becoming a little weaker each time? Those are important questions, and the earlier you ask them, the more opportunity you may have to act. Talk with your doctors. Review your medications. Protect your strength and mobility. Pay attention to nutrition. Don't dismiss new weakness, breathlessness, confusion, or loss of independence simply because someone is getting older. Most importantly, don't wait for a crisis before becoming involved in your own care. You may not control every illness that comes with age, but knowledge can help you recognize change earlier, ask better questions, and make decisions that reflect what matters most to you. Growing older should not mean becoming a passive observer of your health. Stay curious, stay involved, keep asking questions, and if someone you love is over 70, share this information with them. Sometimes one conversation today can lead to an important question at the next doctor's appointment, and that question may change what happens next.